You're listening to In Your Pants with Dr. Susie G, the physiotherapist for your privates, helping you get in the know down below.
Hey guys, welcome to another In Your Pants podcast episode. I'm so glad that you're here with me today. Thank you so much for watching and being a listener and follower. So in today's episode, we're going to talk about pain, which is, as you all know, is one of my most passionate topics to learn about and to educate other people about and to help them live a life that they dream of, one that is not focused on pain. And most importantly, it's a topic and a passion of mine to let people know that there's recovery. Recovery is on the table and there is hope. So to help me do this today, I have asked Allison Sim. Allison Sim is the author of Pain Heroes, Stories of Hope and Recovery. This is a great book. It shares stories of several people who have had chronic pain, persistent pain, and their journey to recovery. And so if you're feeling down or blue and stuck in a rut, perhaps this book can shed some light and give you some hope of that it is possible to live a life without pain. It is possible to still find meaning in life, even though things might be uncomfortable. So I really recommend Allison Sim's book, Pain Heroes. Before we jump right in, I wanted to formally introduce Allison and give you a little bit of her background. Allison is a qualified osteopath since 2001. She has a master's in pain management from Sydney University Medical School and Royal North Shore Pain Management Research Institute. She's lectured at Australian Catholic University, Victoria University, RMIT, and George Fox University in a variety of science and clinical subjects. She's also worked as part of the teaching team at Deakin University Medical School, and she's currently based in Melbourne, Australia. She's working in a pain clinic, helping those with persistent pain get their life back. So without further ado, let's get the show started. I really hope you enjoy it.
Allison, thank you so much for being on the In Your Pants podcast. How fitting. Pelvic pain in your pants.
Thank you so much for having me, Susie. I'm excited to be chatting from across the world.
Oh, yes, I know. Melbourne, Australia, everyone.
That's right, down under.
That's right. Again, no pun intended, right? I mean,
no.
So I wanted to actually start our conversation today by reading from your book. So Allison has a book called Pain Heroes. And I just thought it was really profound. And it is from the introduction, but it's just so great. It states, the people in these stories have generously given their time and permission to share their story because they believe that it has value to other people who have pain. And each of these individuals have had pain that has had a significant impact on their life. It made them feel miserable, disconnected from friends and family, and might have even made them unable to work or look after their families. In some cases, they felt so despondent that they did not want to live anymore. This is what pain can do. It can pervade every bit of a person's life, taking away the good bits and leaving behind distress, medical appointments, medication side effects, and misery. How true is that? And I'm sure everyone who's watching and listening who has ever dealt with pain or is dealing with pain can attest to that.
I think so. And it's interesting when you read it out. I haven't read the book for some time. When you read it out, I think, oh, yeah, that makes a lot of sense. Yeah. It is, pain is incredibly pervasive, and it really can take away life. It really can take a person's life and shrink it right down to being all about surviving.
Right, absolutely. And so just starting off our conversation here about the importance of clinicians understanding modern pain science and really why that is important, but also why is that important in the context of the relationship with the person in pain and the person providing services?
I think that's a really good point, Susie. And I think what it comes back to is the idea is pain science is not a thing. It's not a technique. And that's often what we see bandied around on the internet is, are we going to debunk this pain science thing? It's science. It is what it is. It's science. And understanding it doesn't devalue often what we've learned in PT school or whatever university education we've had or undergraduate education. It just paves the way for understanding why pain is so tricky to treat. And so that's why I think it's important, is not because it devalues anything that we've learned in the past, but it gives us a bit more hope and a bit more understanding. And most of that comes from what we take away from the pain science, which is there isn't going to be a quick fix tissue-based answer for this. And really, that's the crux of it. And then the other thing I think that we take out of it is that if that is the case, what is the most important thing that we can understand? And I think that's to look at the person in front of you and to understand them, because there is so much value in that relationship between the therapist and the patient, and how that drives everything from that point, that it's worth making the time to understand that. And I think it's very hard to do that when we're action-based practitioners. We build a value of ourselves and what we do around what we do with our hands, or what we do with our exercises, or what we do with this technique or that technique. And when we look at this idea that what if just talking and understanding your patient had more value than anything that you did with your hands? And that's kind of what pain science points to. But sometimes it's very hard for us as action people to embrace that understanding and to sit back and to sit on our hands and to stop talking and to listen, because it feels like we're doing nothing.
Right.
And I think that's where the understanding of science can really give us the backing to say, no, actually, this has value. This is worth it. And even though it doesn't feel like I'm doing anything, there's probably more value in this than what I might do with sorting out someone's, straightening someone's spine or anything like that, which is often what we're taught at.
Right.
Yeah, which is often what we're taught at university. And I think, it's easy when you live in a bit of a pain science bubble to think that things are changing, and they certainly are. But I remember teaching at PT physical therapy college in America, and I'd be teaching a pain science subject, and then literally the students would then walk into a biomechanics class where they're learning about how this being rotated this way can do this, and this is the root of all problems. And it's really it's easy to see how people can get really confused and a bit, I guess, disconnected from all of this when you've got people, an entrenched understanding of something, and then these newer ideas that are coming and debunking some of this stuff. So yeah, it can be really confusing.
Right. And also I think it's easier to latch on to those kind of beliefs because, well, it's an answer and it seems logical, right? I mean, in general, it was like, okay, that's an answer. I know what's wrong. But then it just leads people down a rabbit hole of, well, what happens when it stops working or doesn't work anymore? I mean, does that pervade you to be more of a broken person, or that there's something seriously wrong with you? Or, the list can go on, but that is a good point that you bring up, that it's not just in the tissues. And in your book, you mentioned how that can be very hard for patients or the person in front of you to swallow that pill, like to wrap their head around.
It's pretty much you're right. It's pretty much the number one reason that I wrote the book, because I get it. As a practitioner and as a patient, I guess I get that understanding that sometimes it's really hard to shift your focus when you've held this idea so tightly that something's wrong and needs to be fixed and that there should be an answer. And it flicks back to our understanding as a consumer society. And I've had some members of my family going through health issues at the moment, and I get it. Their understanding with the rest of life is that everything comes with money back guarantees. Often things are very black and white, but unfortunately the human body just hasn't read that memo. It hasn't read the rules that says that, this should equal this, and that when you do this, this should, It's just not how the human body works, but we don't understand that, and that drives our expectations.
Yes.
And then our expectations is, as you say, that's where we get sent down the rabbit hole.
Right. And there's also this facing uncertainty, or, uncomfortable with uncertainty. And that's, that is life. It's more philosophical in nature, but it is true. There's a lot of uncertainty in life, and there are no guarantees other than death and taxes for some, but the taxes part, death, I think we all can agree on that. It happens to all of us. But yeah, so, that uncertainty of not only not knowing what's happening to me and my body, but also of when's that next flare up going to come? It's very cyclical, persistent pain.
Exactly. Yeah. I think you're right. Embracing that uncertainty can be a really hard thing, both patients and practitioners, because it's often the lack of control that is one of the worst things. And if you look at the common themes in what people are saying, in the book, there's 8 stories in there, and a lot of them, and I work with pain patients every day. A lot of the stories, a lot of the guts of the suffering comes from the lack of control. And it's that idea that if I can control something, then it's less frightening. And so embracing uncertainty is really tricky. Equally, as you were kind of hinting at before, we're talking about the patient side of things, but also for the practitioners, it's hard for us to embrace uncertainty, especially if what we've been taught in this sort of didactic fashion is, this is the way you do things, and if you do this, the emphasis is that if you do this, people will get better. But then what happens to the practitioners when they don't? When they're doing all these things that they've been taught at school and patients don't get better? And I think that's where pain science gives us a break, because it means that we're not getting cross with ourselves as practitioners. We're not seeing ourselves as failures. We're not putting equally, we're not putting the blame back on the patients. We're saying the science is what the science is, and it tells us that this stuff is really, it's really hard to fix, and that the changes are no longer in those tissues, that they're in the nervous system. And that's probably why we need to take 3 steps back and consider this as a bigger picture.
Right. And keep things simple. And I love that you bring it back to the clinician too, of there's a lot of burnout, and we get into this profession with our heart and our soul and utmost compassion and empathy, and we give it our all. And I can attest to this. I've gone through many classes and courses and certifications and more letters, but that the underlying theme that you just said was, I suck as a therapist because not all my patients are getting better. And, I'm missing the magic bullet. I don't have great hands, like there's something wrong with me. And you're totally right. That's not the case. There is, we just can't predict these things,
Exactly. And pain is really complex. It's really, really complex. And I think you're absolutely right, Susie. We are compassionate people, and we go into it wanting to fix people. And naturally, obviously, most of us are quite driven, because you kind of have to be there to get into our professions. If then you're not doing, if you're not getting the outcomes that you want, then it's natural to reflect, and it's quite natural, I guess, with a lot of those society pressures to think, what am I doing wrong?
Right.
And I battle with that, and I, even in the presence of recognising that burnout's a thing and that we need support, I've had a tough couple of weeks with some CRPS patients that I've found really, really tricky. This disease is kind of what we look to when we define chronic pain, and when we look at what changes go on, we look to CRPS, because it is the worst of the worst. It kind of shows us what goes wrong in our pain systems. And that's the sciencey bit of it, is why this is tough to treat and why it's often quite unresponsive. But what it's wrapped up in is this person who's suffering, and this person who's coming back week after week, who might not be getting improvements. And so, as a practitioner, I'm really lucky to be working in a team. And when I have those thoughts and feelings, and when I'm thinking about those patients at night, which, you know, that's what causes the burnout, really, isn't it? When you're taking them home and you're thinking, why? What if I just did a bit more graded exposure? What if I just did a bit more graded motor imagery? Or, you know, why am I not nailing this when there are some good ways forward? Is I'm thinking about that person and how much suffering they are, and the look in their eyes when they're coming back in. And I think one of the things that I have to keep reminding myself of is to fall back on that team and to fall back on the mentoring and support of people around you. I had a really good chat with one of our doctors this week about that, just a patient that we're co-treating, and I was just saying, I understand the science, I understand the disease, I understand why this thing is progressing, but how do I sit and cope with the sad when this person's just getting worse week after week? And he was really good to listen to my frustrations and to hear all that, and to say, his advice was, first of all, even though things aren't changing, in fact, for this young girl that I'm talking about, she's actually going backwards week after week, understanding that she has this catastrophic history. She has this, this horrendous childhood history of trauma, and that's probably what's driving a lot of her sympathetic nervous system. But also to know that even though she's turning out week after week, things are going backwards, she's got a listening ear, and that without me being there, without someone to touch base with on that regular basis, she's not getting the reassurance. She's not getting a listening ear. She's not getting someone who understands what she's going through. And those things have so much value. Mm-hmm. And so sometimes you need that to be pointed out to you. And his advice to me was keep the faith. It was just to hold steady and to know that, maybe the tide will turn in 6 or 12 months' time. And in that case, she's got the existing relationships, and she hasn't gone, she hasn't, I guess, vanished off our books, that she's still there and able to keep accessing help, even if it's not making functional progress for her.
Right. And thank you so much for sharing that. That takes a lot of courage, but we're all, we've all experienced those cases, and many, where we just want to help so much that it's just out of our control. And really, like you said in the beginning of this conversation, is if that's all we can offer is support and an ear to listen and validation that we're here for them, that might be just enough to know that there is someone that loves and cares for them and is rooting for them, and they're not alone.
Yeah.
And so I think that
that's right.
Important.
Yeah.
Wow. Well, thank you. Oh my gosh. I'm like, okay. So we segued that into all this information that we talked about. How does this change our understanding of chronic pain conditions like pelvic pain? So a lot of my listeners are those that are experiencing and suffering pelvic pain. So I would love your take on that.
Well, I think that's pelvic pain is a really big issue, isn't it? Mm-hmm. And because it's in your pants and it's down there and it's dirty bits and there's shame and all those things associated with it.
Yes.
We don't talk about it. Mm-mm. We just don't talk about it. And again, things are changing. We're less ashamed about talking about periods, and but still, it's often just so normalised as being women's problems, or that's just what you have to suck up or deal with it. Right. And it's just not the case. And we know that our understanding of pelvic pain, things like endometriosis or musculoskeletal components, or pelvic pain can be incredibly multifactorial. But just our understanding of it, and picking up young girls, to be able to have these conversations with young girls and say, hey, a little bit of period pain's normal, but you shouldn't be taking days off school on a regular basis. And that if you are, that we need to talk about this. We need to actually try some things, because, again, if we look back to the science, if we catch this stuff earlier and we stop more of the peripheral sensitization, if we stop people suffering, if we stop them sort of falling into the more psychosocial stuff, so they're losing days of school or work there. It's having a big impact on their life. They're starting to define a lot of things around pain. If we can stop people going down that path by, maybe hormonal treatments, maybe exercise therapy, but maybe talking about it. And that's not to normalise it or talk it away, but to actually start engaging in dialogue and saying that, rather than being reactive and going down the path of having multiple surgeries, let's talk about this from the get-go and stop this thing from becoming a thing. That's something I'm very passionate about, and is this idea that we can catch a lot of this stuff a bit earlier, but we've got to start having the conversation with our girls.
Oh, I'm so glad you brought that up, because I say that all the time. And I predominantly treat men who have pelvic pain. And so it's very similar, where I would even say that women have more outlets or available resources, whereas men, like my husband would say, I would have no idea who to talk to or which doctor to start with. What do I even look up? And as you know, the internet is a double-edged sword. It can be very helpful, but it's at the same time, it can be very harmful depending on what you come across. And there's a lot of misinformation. So you mentioned this rabbit hole, and they struggle with that too. I mean, genitals mean a lot. There's a lot of real estate, and of course, it only takes one spitting twice shy, right? It only takes one time for something to disrupt the normal functioning of things down there. And then there's this just really huge fire. Like, it's a little one, but then it can grow to a really big forest.
Yeah, big cascade. And
put it out.
And you're absolutely right with the men. If a woman's having a bad day, there is even though we're saying there's not a lot of society's acceptance or understanding of period pain and stuff like that, it is still a bit more understandable than a bloke who's saying, my testes are really sore. No one wants to talk about that.
They're not going to the gym saying, how are your testicles? My penis hurts today,
Yeah, that's exactly right. It's, there's way more taboo around that. So you're absolutely right. It's associated with shame. It's associated with manhood. There's just so much going on there. And as you say, the blokes are even worse off than us in terms of talking about this stuff.
Yeah. And not to minimize either situation, obviously. Everyone
absolutely not. It's just,
battle and struggles and all genders, all walks of life. I mean, there's enough to go around to, there's so much out there culturally, society. And so, you mentioned CRPS earlier in our conversation, and just for our listeners out there, and this will segue into my next question about your case report, but let's talk about CRPS, what it is, and the relationship between pelvic pain and incontinence and CRPS.
Oh, that's okay. So it might not be that relevant to your listeners. If most of them are patients with pelvic pain, then it might not be something that they're coming across. But perhaps for practitioners who are dealing with people with CRPS, as a definition, chronic regional pain syndrome, CRPS, is a version of the nervous system where things go fairly pear-shaped, and they go fairly pear-shaped in a predictable way. So often it comes after immobilisation of a limb. So perhaps we look at a fractured wrist or a fractured ankle or something like that. They often are immobilised for a period of time. It is often associated with higher levels of trauma. So if someone's particularly stressed about their condition, or if there is trauma associated with how that condition actually came about, for example, accidents or, really traumatic things, people don't go out or get in their car to expect to have a car accident, and that can be incredibly traumatic. What tends to happen is that this, instead of getting good tissue healing, or sometimes even in the presence of good tissue healing, the nervous system gets a little bit wound up. And so if we take the example of, say, a fractured wrist that's been immobilised, what can tend to happen is that we start to see colour changes. sweating changes, hair changes. So all these things that aren't normally associated with something like a fracture that start to affect different parts of the body. So usually it would start in the area that the damage has occurred. So we tend to see these things going either pink or blue. They tend to get swollen, or sometimes they go white as well. So hot, cold, what else? And often associated with incredible pain. So and pain that's of a particular nature, so-called neuropathic pain. So often patients describe it as being sharp, shooting, burning, electric, quite classic neuropathic descriptors. One of the things that people often present with is what we call allodynia. So that it really hurts to touch the area. So they get really sensitive to having things like bed sheets on a foot, or wind, or the air conditioner. They can't cope with the air conditioner being on their skin of their affected limb. And as well as that, they often find it hard to weight bear if it's a leg, or to use the hand. So it often gets a little bit atrophied. And then sometimes in the worst case scenarios, it can spread. So it can go from a particular limb to other limbs or to other areas of the body. So it's a pretty ugly condition that often carries with it an awful lot of suffering and pain.
And in your case report, is it a combination of CRPS, pelvic pain, and incontinence? Because everything that you've described, I can tell you that I've seen happening in the genitals, and because it is this nervous system response. So men will often report changes in blood flow to genital area, burning, stinging, sensitivity to clothes or underwear or anything light touching the penis. And then there seems to be this disembodiment that happens too with their genitals too, like feeling weird and not them, not part of their body. And so that probably has to do with the cortical changes. And
exactly
up the day. And so I don't know if this is what your case report goes through, so I don't want to take the thunder away.
No. So but you're absolutely right. And the cortical changes that you're referring to in the limb, what we tend to see is a bit of a neglect. Often people will either describe their limb as being not their own, or enormous, or ugly, or hideous, or if you ask them to perhaps draw a picture of their body, they'll draw it as either incredibly small or incredibly large. So they lose the context of what that limb is, and that's because they're not using it, and so they don't get that reassuring normative feedback into their cortical areas of their brain. There's absolutely no reason why exactly the same thing can't happen with the genitals. And I think vulvodynia is a great example of where we see a lot of these very similar changes. So we can see the allodynia, where people are so sensitized that they can't wear underwear or they can't wear pants. That light touch sends them screaming. And often you'll see a lot of mucosal changes and things like that as well. So those systems are being involved. For CRPS, diagnostically, there's a set of criteria that are called the Budapest criteria, and they involve having the affected limb having a certain number of those criteria. So the swelling changes, the temperature, the colour, all of those types of things to be technically classified. But obviously it's a spectrum, and really CRPS is just the worst of the worst when we look at neuropathic pains. It's kind of how it expresses itself in its worst beast. For the case study that you're talking about, the case report, we're in the process of writing up and sending in a case report that we've treated on a patient as a team who, and the young girl involved started off as a minor sprain strain of her knee, and then spread to her upper limb on the same side. So she started with CRPS in the knee and then spread to the upper limb. As this disease progressed for her, she started to notice that she was getting some incontinence events. And these were happening without her noticing, so she actually couldn't feel the sensory changes of actually having had, having wet herself. But she would smell it, or she would notice it, so she couldn't feel the warmth, She couldn't feel the wetness because the sensory changes in her limb and obviously her pelvis were so bad that she wasn't feeling it. But what she would notice was that she would actually see the colour changes, or she would smell the urine. So that for her was just devastating. She was a young girl and she's at university, so it was quite frightening. And obviously, for her pain specialist, it's not something that they would tend to talk about. They're quite focused on the limb. They're quite focused on what's going on in the area, and it was not something that we'd seen or dealt with very, very often. Or it was just not something that I had thought about much. But then we did an MRI to make sure there wasn't MS or other sort of more central nervous system or central processing issues going on. And that was all clear. And then it just made sense to say, well, if we get changes in either skeletal or autonomic muscle tone in other CRPS cases, why wouldn't it affect the bladder? That makes total sense. And so this young girl, because she had so many practitioners and had seen so many people, she was quite relieved that we were able to do that in-house, that we were able to do an examination and treat that in-house, so she didn't have to start with any practitioner and go through all of her story again.
Right.
And we very quickly identified that she didn't have she didn't have any voluntary muscle control over her bladder and over her pelvic floor, that we were able to rectify pretty quickly with just some biofeedback and some training. And she then went on to do a bit of home-based training with a biofeedback device. And within 2 weeks, the incontinence events had reversed. So she was getting to a point where it was happening almost daily, and she was it had happened twice at university, so she was pretty ready to pull the pin and not go to uni, which you can understand. I think that's quite a frightening thing.
Totally.
And so for her to be able to come back, and it happened within 2 weeks. So it was for her to be able to come back and say, actually, this is reversed, and I can feel when I need the urge. So it was essentially both skeletal and autonomic components that we just rehabbed with a bit of biofeedback. And so people who work with stress incontinence wouldn't be surprised by those results at all. I think the stats are somewhere in the vicinity of 8 to 12 weeks of pelvic floor training reverses about 80% of stress incontinence. So
it's pretty high,
pelvic physical therapists are kind of going, that's normal. I guess for us from a more neurological or pain background, the case itself makes sense, but it's not something I'd come across or that we'd talked about very often. So that's why I thought it was a really interesting case. And I've been lucky enough to get Dr. Jane Chalmers from University of Western Sydney on board as a supervisor in getting this case written up, and Jane's incredibly experienced with pelvic pain. That's her bag, but she's also done a lot of research in CRPS prior to her PhD. So I was lucky to have her there for advice and support in getting that up and written.
Oh, that is so awesome. And thank you for sharing the treatment and how things can change. Things are optimistic, things can change, and they're adaptable, and it may not be easy, but some cases are harder, as you said.
Yeah, that's exactly right. And the interesting thing with that case, which causes a lot of reflection for me, is, well, why can we rehab her bladder and her pelvis, but she's not getting good rehab with graded exposure in her limb, which is really interesting, and also the rehab changes to her pelvis didn't change any of the allodynia or the hyperalgesia that she was getting around her perineum, which you'd hope in an ideal world would translate through. But I guess the shining beacon, the ray of hope in her bleak sky is that at least she's not incontinent, and she can go to university without having to, as a young girl, without having to be concerned about embarrassing herself in that situation.
Absolutely, which would only make things worse in terms of a heightened sense of awareness and threat to, being able to go to university and have a really, not be embarrassed, as you say. So
try and be normal, try and live a normal life, right? That's our intention of keeping her at uni is to, to keep things as normal as we possibly can while the rest of her life's kind of falling apart.
Right, exactly. I love it. And that's what your book is really about. And I think you did mention in here about, to get better, but to focus on function and not on pain. And that's kind of what we're alluding to is like be getting back to normal despite, adversity or a challenge of how can we still make life meaningful in the face.
Yeah, even in the presence of pain. Yeah. You're right, Susie. That's right. Yeah, we don't necessarily have to take the pain away. Although for those neuropathic pains, the longer I work in that, I really understand where the patients are coming from when they say, I just don't want it there. I just want it to be gone. And for us as practitioners to say, oh well, you can focus on function and we don't have to take the pain away. That it is a bit of a second best. I get that. I understand that coming from the patient's point of view.
Absolutely. And from my own personal experience, I know that that's, someone telling me that my reaction back in the day would be like, I'm going to slap you right now. What are you talking to me about? Like, get back to my, like, you try dealing with this, and getting back to normal. Like, I probably said that in a few little words and not appropriate, but
Yeah. No, but I think that's exactly, and that's where the understanding comes in, is that if you're sitting up in your high and mighty tower and you're asking lots of closed questions and you're telling the patient what they should and shouldn't be doing, they are, of course, they're going to be sitting there looking at you and thinking, how would you know? How would you know if you haven't really understood their story and if you haven't demonstrated that you've understood their story and that you've listened? Of course, the thoughts that are going to be going through their mind is, what would you know or how would you know? And you haven't lived in my shoes.
That's right. That's right. It's empathy, compassion, listen, and be a human with that person in front of you. You're human too. We all have struggles that we're dealing with. So, oh my gosh, Allison, thank you so much for this very enlightening and wonderful conversation, all this wisdom you shed upon us. Thank you.
Oh, thank you for having me to chat, Susie. It's been lovely.
Well, thank you. And, I know everyone's going to be seeing my troubled child in the background, so I apologize for the barking and the whining. But how can listeners get in touch with you if they wanted to? Well, obviously, I'm going to link your book in the show notes, but is there any other contact information or social media platforms?
Thank you. You've been very kind. Very kind with your support of the book. Thanks, Susie. I am on Twitter. I am Beyond M Pain. On Facebook, I am Beyond Mechanical Pain. And everywhere else, I'm just Alison Sim. So people can, my website as well is beyondmechanicalpain.com. So there's contact details there for email and everything.
Great. Great. And when's your case report coming out, you think? You guys are writing it up now?
We're very close to having it ready to submit. So hopefully in the next little while.
Great. I know it's a process. It's a long process, but thank you for the efforts for all of you. And I just certainly can't wait to read it and share it with the rest of the world. So thank you very much again for all the work that you do for us clinicians and for everyone that you're touching their lives as patients and people who need help. So thank you again, Allison, for being on the show and having this chat with me.
Wonderful. Thanks, Susie.
Thanks for listening to today's episode. Be sure to head on over to drsusieg.com where you can get more information, show notes, and related articles on today's topic. Also, if you like what you're hearing, head on over to iTunes, subscribe to the podcast, and leave us a rating and review. We'd love to hear feedback. Thanks again.
I apologize for the barking and the whining.